Hello and welcome to my brief presentation for the implementation of a readmission risk assessment tool for heart failure patients. I will briefly give a background into the problem, the significance of that problem, my PICOT question. I will then review the findings related to the study analysis that I conducted. I will give a quick overview of the change theory I selected for my implementation plan, and then give a brief summary of my implementation plan. Chronic diseases have become a significant issue in the United States, and particularly for the older adult population, or those greater than 65 years of age, of which 75% of individuals are coping with the elements of some chronic disease. The most remarkable effect of these chronic diseases is the negative effect it has on an individual's health-related quality of life. This is a term related to a person's ability to continue out their daily activities without significant deterioration or limitations. One of the primary issues with chronic illnesses, particularly heart failure, is that it decreases the individual's health-related quality of life in such a way that there is a connection to increased hospitalization rates and readmissions. Some of the impacts of heart failure alone can cause large rippling effects on our healthcare and national systems. For example, the total direct costs for chronic heart failure patients in 2012 were estimated to be $30 billion, and it's projected to elevate up to almost $70 billion by the year 2030. As I'm sure the majority of us have seen to some extent, the detrimental effects that frequent hospitalizations have on patients. These can range from financial issues to family and social issues to overall disease progression. Responding to costs has always been a priority of hospital systems, professional organizations, and federal subsidies for decades. Nevertheless, we continue to see negative readmission impacts and overall health trends for these patients, particularly heart failure patients. And it's being seen economically and in healthcare trends. Something is being missed. So my question that I had was, for adult chronic heart failure patients, does the use of a risk assessment scale or tool to identify patients at risk for readmission, compared to patients discharged without the use of any readmission risk scale, affect 30-day to 6-month hospital readmission rates? In my clinical exposure, heart failure patients have consistently been the ones to return, month after month, year after year. Raising awareness and having a flagging system to identify at-risk individuals for readmission is one method of changing the current methodology and practices and ideations in order to wake up clinicians, so to speak. Not just to work with more effort, but to explore new processes and to help this patient population. Findings from my 10 articles showed that improvements for readmission rates were possible with the implementation of a specific heart failure readmission risk assessment. Many of the scores were C-statistics scores, and they valued up to 0.721, with 1 being a perfect prediction for some studies, and accuracy predictions of 32.9 to 95% of patients and others. So there was definitely some variability in those. But if readmission score risks are somewhat predictable, why does standard of practice not include risk assessment scores above generalized or required national models or standards, such as CMS and other professional models? Because there are some specific factors that need to be addressed when utilizing a readmission risk tool that complicate the scenario, such as, when should the assessment be completed during the hospital stay? Should it be done on admission, at discharge? How frequently during the course of a hospitalization? Should readmission risk be entirely controlled and operated by clinical personnel, or should the risk be automatically scored and information gathered through the electronic health record? Continuing, should there be an inclusion of unique social markers and personal economic variables, or should mortality risk score be included in a readmission risk assessment? Is predictability maximization of the risk assessment tool an indicator of a good tool? Or should that not overshadow the importance of risk identification, which then translate into intervention? Should there be an inclusion of a tiered risk system or simply one at-risk category? Should assessment tools include dozens of prediction variables, or do simple checklists still have reliable results? These are all questions that need to be considered when creating an implementation plan. It's not simply as simple as looking at a model, looking at something that's been validated and implementing it, but specifically targeting readmission risk for each unique situation. And because of that, each study that I analyzed saw different outcomes based on these variables. In preparation in regards to the implementation plan, I chose to use Lewin's change model. Lewin's change model has 3 stages. The first is unfreezing. This is starting at the core. It cuts away the normal idea of this is how things are done and opens people up who are hesitant to change or they're fatigued to change with the idea that change is a good thing. The next stage is change. This is when people begin to act and support new behaviors. To accept change, individuals need to understand how it will benefit them. This is the time to implement new methodology, new ideas and practices. The third stage is the refreeze. It's about embracing new ways of working. There is stability, consistency, confidence, and people are comfortable with the new work methodology. Starting my implementation plan, particularly during this time of the COVID-19 pandemic, many healthcare workers are not apt to the idea of change. It's due to physical, mental, and emotional burnout. Many people are currently experiencing change in protocol, facility procedures, and areas of practice in redeployment. Preparation for change, at least in my opinion, for the next year is going to be vital to the success of any implementation strategy, and that is why I specifically chose Lewin's model. To unfreeze the involved parties, which are the nursing staff and leaders, case managers, providers, and to some degree the patients, I want to conduct a pre-implementation survey to evaluate support and organizational readiness for change. This is an excellent time to begin recruitment for assistance, especially when people demonstrate interest and questions regarding the new practice. I then want to provide study data. I want to educate, debate, and create an understanding as to the why of implementing a risk score assessment. When people begin to understand the why, they start to become self-motivated rather than feeling pushed into doing tasks. And finally, by addressing concerns and demonstrating that the risk assessment tool can be utilized to several key groups such as nursing leadership, case management organizers, and provider group leaders, I can get a stronger buy-in and assistance in improving participation and the meaning that it has to the workplace leaders. In the change phase is when I will implement the readmission risk assessment for the space of 3 to 6 months. During the course of the implementation, these stakeholders will have some responsibilities, and they are generally outlined here. Pause if you need to on the video in order to review this list. Addressing some of the specific factors mentioned earlier is important regarding the implementation of a readmission risk assessment score, and I have listed the answers to almost all of those concerns here. A utility evaluation will be done every week to 2 weeks to analyze the effectiveness and overcome any problems that might be proposed. This primarily is due to the fluctuations in hospital staff, patient flows, and in general the unexpected hurdles that are sure to be present during the course of such a longer time period. Especially right now, if we continue current trends, we don't even know what to expect in healthcare over the course of 2 weeks, let alone 3 to 6 months. In the final stage, or the refreeze stage, I want to conduct a post-conclusion survey to the staff to question opinions, the utilization, ask for any suggestions, and the effectiveness of the tool. The main evaluation of the tool will be done by statistically comparing the amount of individuals who receive the readmission risk assessment and the readmission rate of the same group within the time period of the risk assessment tool utilization. My hope is that yes, we can cut back the number of readmissions for this sensitive chronic illness population. If that's not possible, to at least implement a change that helps to raise awareness of the unidentified variables that can influence readmission in the hospital, apart from clinical pathological findings as well as caregiver observation and an opinion. Thank you for watching this presentation. I'm looking forward to hearing any feedback that you might have.